We were an orthopedic-only specialty hospital in 1940 at the bequest of Alfred DuPont's will, and then changed to a multi-service hospital in 1986. And this is the brand new patient care towers that were constructed just over 18 months ago, where all of our patient floors are now. So why are you all here? It's because scoliosis is probably the most common inherited condition that affects children and adolescents. We estimate that 10 million people just in the US have scoliosis, and whether you're a family like this or you're a family like this, it affects every aspect of multiple generations in that family. Some people might have been observed, some people weren't even aware they could be treated, some people were treated with surgery, some people just have the very mildest form of the condition. So the genetics are variable. The genetics are still trying to be worked out. We thought we were onto something and now we're moving in other directions. But the important thing is that the work on genetics still continues because that area of technological innovation has become cheaper and faster. Just like microchip innovation, it's becoming cheaper and faster to analyze the entire genome very quickly. I'm going to give you a little historical perspective about where we came from. People used to be put in traction. And this may seem bizarre to you, but I want you to remember that at that time it was state of the art. This is the machine of Hippocrates, where they used to stretch people out, what we now refer to as the rack. And coincidentally, we still use traction on some of our patients with the most severe curves. This is a patient that's hanging with gravity to try and get a sense of spinal balance. This is a patient in sort of a trapeze netting configuration prior to surgery to loosen up the spine. And not too long ago, people used to be casted and taken to the operating room in a cast, and we would operate through that cast. I mean, when I say we, I don't mean me, but my older mentors. And you would do the operation through the cast, and then turn the cast straighter, because you then mobilize the spine and wait for it to fuse. This was fraught with lots of reoperations because people didn't heal, people got infected. And a technological innovation that really helped the correction was the Harrington rod. Marty touched on that earlier. It's a single quarter-inch diameter piece of stainless steel that was ratcheted up to correct the curve in the frontal plane. But what it did in the side view, which one's the pointer, guys? Okay. What it did in the side view was make people very flat and subjected them to disc degeneration at the level above. And I'll get to why a little bit later that's important. Harvey, can you advance me one? So where we are now is we can get pretty spectacular corrections on most curves. There's a rapid recovery that doesn't involve a 6-month hospitalization and much more earlier return to activities. This is an actual patient and her x-rays are on the left. And our own patients are pushing us. She asked me, can I do backflips now? And I'm like, I'm not really sure. Why don't we try? So I videoed her in the hallway doing one. She sent me a video a week later, she was doing 3. And this is the kind of thing where our patients are pushing us to do. And so innovation comes from many different ways. It might come from surgeons, it might come from researchers, it might come from scientists, it might even come from industry. But what we have to remember is that we have to be open to some of those innovations. Patient-based outcomes are really at the heart of what's happening around medicine now. I and Dr. Sandami might agree that an x-ray looks really good, but what really matters is how the patient feels about their health-related quality of life after such an important surgery. Fortunately, and I can bore you with all the papers, but what I'll summarize our literature regarding posterior spinal fusion for adolescent idiopathic scoliosis is that 95% of patients are very happy with their outcomes and would choose it again, given the choice. We now look for balanced corrections, trying to keep the fusions as small as possible. The reoperation rate is not 50%. It's probably more around 5 to 8% over 20 years. And the 20 to 30-year follow-up studies that all the parents ask me about are lacking. They're limited to 2 patient populations in Iowa and Sweden. And the techniques that were used during that time aren't even used today. And so we're trying to measure something that's a moving target. With each innovation, we have to recalibrate what we're measuring and how we're doing it. And I often ask the question, compared to what? Compared to how your child would be without treatment is the best comparison, not to someone with a normal spine. And that's really important for families to remember. Unfortunately, your child or you have scoliosis. We can't change that. What we can change, perhaps, is the future if their condition is progressive. So what's important about today's techniques is that we've recognized the sagittal plane, and Dr. Herman touched on that. That's the side view. That's right here. And now we see that much better than ever before. The technical innovation that came along are pedicle screws. It made posterior surgery much more effective than anterior surgery, much more effective than hooks and wires, and also made the constructs much more stable so that patient can do backflips at an earlier stage than not. But what's really happening around medicine, besides patient-based outcomes, is trying to improve safety, quality, and value. And scoliosis surgery is no different than cardiac bypass or total joint replacement when you look at these features. We're safer now because we have intraoperative monitoring. The rate of paralysis is so low that it's almost an aberration when someone with AIS has a neurologic problem that's permanent. We have now the opportunity to intervene very early in the operating room to reverse some of those impending injuries and keep these patients safe. Also, the transfusion rate is declined to now at our hospital in the single digits. It's because we're using advanced anesthesia and chemicals and different techniques for exposing the spine that reduces the blood loss right off the bat. We also have contemporary pain management. Narcotics were the big reason that people spent a lot of time in the hospital. Now we manage pain very effectively by using other medicines besides just narcotics. This reduced the length of stay in the hospital from 6 months to about 3 days. And the other thing that's really important for patients is that the only way we can see the spine is X-ray, at least now. And repeated X-rays over time increase a person's lifetime chance of malignancy. So many of us are fixated on the lowest possible dose of radiation, and now that's possible with EOS Imaging, one of our sponsors, in their ultra-low dose X-ray. And so it gives us, as surgeons, awesome images in 3 dimensions. We're able to understand this condition much better than we ever were. But the advantage for the patients, it's much less radiation than they were getting before. Advanced surgical techniques and ways to make the spine more flexible give us better corrections. Like I mentioned, we can conserve blood. And neurophysiologic monitoring. These are spinal cord potential waves that we watch during surgery with our neurophysiologic colleagues. They'll communicate with us and with anesthesia during the operation. Their only job is to keep your child safe that day from something that might happen during the surgery. And they do a great job at doing that. In fact, in this region, we're blessed with the best group in the country doing our spinal cord monitoring at our hospitals. So how do we take a typical patient like this, who could be in the audience today, a 7th grade student who's had a progressive curvature. 1 month later, she has this X-ray appearance. This is what the 3-dimensional view of her spine showed before surgery. You can see how twisted and rotated the spine is in this 3rd dimension. We were never able to see this before. And the other thing we were never able to see was how lordotic they are in actuality, just as Dr. Sandani mentioned, that we're recognizing this. This is our preoperative plan much more effectively. This is the post-operative 3D rendering. And this is our report card. How well did we straighten it? Well, that's obvious on some of the X-rays, but how well did we derotate? How well did we change that sagittal plane? Does it look like that model over there, or is it very flat like the Harrington rods? Her hospital course changed her to pills on the first day. She was eating, she was walking on the 2nd day, and discharged home on the 3rd day after surgery. At home, she stopped all of her narcotics during the first week. Alicia McCarthy, one of our nurse practitioners, is going to talk to you about how to take your child home after surgery and give you some real-world tips about what things might be like when you come back. And she returned to the office 1 month later. She had already gone back to school, and we cleared her to start playing basketball in a light way so that she could be ready for the season later in the fall. Well, that's a short-term outcome. That's excellent. But what you guys want to know is, what are the long-term outcomes? And because of you participating in clinical trials like database registries and the HARM study group, we've become the gold standard for multicenter research. It's important to gather large populations and compare them to each other and compare them to other conditions in which we can make a big difference. This is now the largest database of scoliosis patients ever assembled, and it's prospective. And that means they were enrolled before they had the intervention, not looking through charts later and trying to pick out details. We were collecting this stuff from the beginning, which makes it much more valuable. And it's been a real important academic engine of discovery and evaluation of what we're doing. Are what we're doing important to people's lives? We think so. So these are some of the contributions that the study group has made, specifically in treatment of AIS. We now have a classification system. We now have guidelines for surgeons to choose fusion levels. You might think that's pretty straightforward. If you've got 6 spark plugs in your carburetor, you got to replace those. You got 4 tires, replace those. It's not like that. We want to customize the treatment for particular curve types. Surgeons have lots of questions about where to fuse, to where. Now we have some guidelines about that. We can predict how your pulmonary function is going to be after surgery. We now have, for the first time, 5-year outcome studies based on the current techniques that we're using now. Dr. Sandani is leading that charge. And we're also focusing on the long-term effects of what the spine is doing below the area of the fusion and how to maximize that motion well into adulthood and try to reduce hospital stay to those hospitals that are doing this really well. We want to copy what they're doing so we can give everybody that benefit. What's going to happen in the future? We want to work more on identifying best practices. What does Dr. Sandani do that's really changed the way his patients act after surgery? What does Dr. Herman do in the operating room before surgery that might be important later? Things like that. We want to adopt those best practices for everybody. We want to develop these more advanced 3D treatment strategies. Now that we know what the spine looks like in 3D, we should respond to that with the treatment in 3D and the evaluation of that. We have 5-year data, early 10-year data. We want to get to the point where we have reliable hundreds of patients in the 20-year data group to really understand what the long-term future of these patients is going to be. Clearly, we would love to identify a genetic risk factor for progression. So we can pick out Julie or Jill or Bob and say, you 3 out of the 100 that we've seen are most at risk for progressive curves. We're going to customize treatment for you. And evaluate some of these innovative procedures that might be able to preserve spinal motion, which has been the holy grail of what we're trying to do without a fusion. What about cerebral palsy and not just AIS? This is a population of patients where the surgery is costly, the complication rate is high, and people can have significant morbidity or be in the hospital for a long time. How do we make this surgery better? We study it. We can now monitor these patients with spinal cord monitoring very effectively. We can look at who's going to get a complication at the beginning so we can anticipate those complications later and be preemptive rather than reactive. And what are the best ways to do these corrections so patients can sit in a wheelchair properly and go to school? And how do we reduce the bleeding that might happen, because these patients bleed quite a bit? We've solved some of those questions, but now we want to really look at, is this surgery changing their life? Is it keeping them out of the hospital more? Is it decreasing the burden of care on the family? What about the collateral effects on the well children in the family? How can we improve their life as well? When bigger curves come along, we take what we've learned in the past with treating more of the routine curves, and an outcome like this is only achieved when we tried to perfect outcomes from smaller curves. And again, looking at the 3D, this is really our report card. So how are we going to improve tomorrow's treatments? It's all about 3-dimension correction now, and more centers have the ability to study their patients in 3D. We have to continue to make this surgery better and safer. There's this strive for perfection that will give patients reliably good results if we try to do that. We want to ease the recovery. It's still a significant surgery that we can make better. We want to decrease variability. Many of us are artisans practicing a craft. We want to get past that and standardize our treatment so that it doesn't matter what hospital or surgeon you may go to, you're going to get a good treatment and good outcome almost every time. And we want to improve those outcomes to maximize motion, function, and mobility in the long term, not just in 4 weeks or 2 months. Genetics is going to play a huge role. It used to be about twin studies and genome-wide association studies. Now it's huge databases and computers looking at the entire genome over thousands of people at once. Who's going to progress and who's not? Who's going to benefit from a short fusion and not? And improvement of the non-operative treatment methods that they're talking about in the other room. What about the role of nutrition and bracing and diet and exercise? There may be a pill that you take that's going to modify your spinal growth so that fusions become unnecessary someday. How do we spread the message? We educate people. We have people observe us in surgery. We write about it. People like you participate in important study groups like this and communicate with each other and drive us to be better. We spend a lot of time researching this, but we also talk about it and we try to spread the message so other patients and surgeons can learn what we're doing makes a difference. And then focusing on quality and safety. We have checklists in such a complicated procedure like scoliosis surgery is no different than building a skyscraper. There are things you got to do every time and you can't forget one step. And that's what we do in the operating room. And we look at that with benchmarking, and Dr. Newton's going to talk about that later, where we stack ourselves against each other. What's this guy doing that's so much better than all the rest, and how can we get to where that person is? And looking at patient satisfaction is important. But when it comes down to it, I can show you a lot of data and pictures. What it comes down to is these pictures and trying to give kids a normal life if possible. Thanks very much.